All right. So I wouldn't call Chip a warm-up act. He's really sort of the main event, but he shares a lot of information. One of the things I like about Chip is that he's not afraid to challenge us as pediatricians and practice managers and pediatric practices to get our act together and look at our practices, look at them not just as medical homes delivering great care, which we are all championing, but also for us to be appropriately and fairly compensated for the work that we are doing. And so um, he may have come a little strong about some of the MCOs and this, that, and the other stuff. And these are these are these are emotional times, and I think we just want to make sure that we are absolutely speaking up for what's right for kids and pediatricians. I think Chip did a lot of focus about what you can look at within your own practice, your own data, your own contracts, and speak up and set up opportunities to try to do things better. I think Priya, Korea, and I are going to chat a little bit now about value-based care in pediatrics and opportunities for pediatric practices to work together, and some of the challenges and actually some early successes. So there's lots of conversations about value-based care, and ultimately this equation keeps coming up, where value equals sort of the quality of the care versus balanced against the cost. And how do payers want to improve value? They want to spend less. We can make you deliver more value care if we just reduce cost. What are pediatricians trying to do? We are trying to advance and champion the best care and the best outcomes for kids and our families. And that's sort of raising quality and being cost sensitive about that. And everything we do is informed by the tension between, these two market forces. It's important to recognize that all this talk about value-based care and Chip talking about, the enhanced payments going to Medicare providers, value-based care has its origins in Medicare. Because let's face it, adults are sick and expensive. And as time goes by and you're a senior, you're usually not costing less to the healthcare system. More and more stuff happens and it takes more and more resources. So there's a significant illness burden and expense and lots of unmanaged and excess care, which is why all these value-based care opportunities have their genesis and early work in the CMS space. It has sort of percolated down to some commercial plans and state Medicaid programs, but what's the opportunity in pediatric care? It's a challenge because let's face it, most kids are healthy, certainly compared to seniors. Over 90% of the kids that we care for are relatively healthy with manageable illness and some common chronic conditions. There are boys and girls that we care for, and we know about these boys and girls with significant, major, complex, and chronic illness. But it's a tiny number of kids. 5% of the kids account for 40% of the total pediatric spend. And that spend isn't happening in your practices. It's happening with specialists in hospitals and other sorts of places. So where's the value opportunity in primary care? Trick question. What's the most common hospitalization diagnosis in pediatrics? Normal newborn. Now, I'm afraid to ask, how many of you have delivered a baby in your practice? So, the most common pediatric hospital diagnosis is never seen in primary care practice. The next most common diagnosis are actually NICU babies. So babies who are born with problems at birth, respiratory illness, cardiac illness, neurologic problems, genetic problems, they spend a lot of time in the hospital and it's a big spend, but we're also not seeing them. In the first year of life, we see a lot of boys and girls and there's we do a lot of care, but The hospital diagnosis that we can't control is sort of out there. So that brings us back to what's the value proposition for pediatrics and primary care pediatrics if we're going to try to make a difference and deliver more value. And part of it is, how do we improve quality? How do we improve outcomes in a cost-effective way? Not simply how do we do care more inexpensively. We should be paid fairly and appropriately for the work that we do. And we're fortunate to have Sue Cressley and representing the American Academy of Pediatrics. But last year, the AAP and others, Jim Perrin and others, and the AAP Committee on Child Health Financing put out a position paper that I know no one here read about what's the value proposition for pediatric healthcare. And I'm actually going to walk through this real quickly because I think it's just important to understand that there is a framework. And the framework isn't simply what are we being paid for in 99213. So recommendations for value in pediatric care, and I'm going to move through this quickly, and the reference is there for folks who want to read it. But if we're going to start talking about value and value-based payment arrangements that include the coverage of children, the AAP and others recommend that you need to recognize that it's a long-term value proposition. Also, if we're going to reform payment reform in the value-based space, we got to recognize and address early childhood adversity and social determinants. We have to look at appropriate metrics and data collection over time, and also recognize that there may be racial, ethnic, and other disparities that need to be factored in. And we have to figure out how to address health equity and social determinants so that it's not simply one set of payment and standards for commercially insured kids versus Medicaid insured kids. All kids should receive high quality health care. And the payment strategies need to preserve and reinforce and build on preventive and early intervention. A lot of successful outcomes in kids aren't achieved narrowly in the pediatric office alone. We work with schools, we work with preschools, we work with healthcare systems, state and community agencies, payers, and other sorts of folks, so the value arrangements need to facilitate those. We spent a lot of time in many of our meetings over the last couple of years recognizing that there's an explosion in behavioral health needs in our kids and families. And so value-based payment strategies must promote integration of behavioral health and social services in both primary care and subspecialty care settings. People talk about risk stratification so that if we begin to develop models that address this, we need to not just look at medical complexity, but also parental and social complexity and social determinants of health. Expecting a family that lives in a shelter or a family that's struggling with illness in the parents or those sorts of things to deliver on the best care for kids may not really be fully capturing the big picture. Payers use a lot of risk algorithms to sort of develop pricing and those sorts of things. Very few of these are actually validated predictive risk algorithms for kids, for children. And Priya will acknowledge this, these are all adult hand-me-downs. And most of those clothes don't fit very well. New technologies keep happening. And pediatricians and families are using them. And some of them are clinical technologies, and some of them are just other technologies. And they need to be baked into our care models, and they need to be compensated and funded appropriately so that we can do those things. And then lastly, there are new healthcare delivery systems like accountable care organizations or clinically integrated networks that are beginning to contract for value-based payment. They exist all over the country. And the AAP's recommendation is if you're providing care to kids, there needs to be a pediatrician at the table so that we are actually speaking up for kids. Which is transitioning to our next point, that actually there may be value-based care arrangements, but around the country there are now pediatric clinically integrated networks that have emerged to sort of better address the unique needs and challenges of quality care and appropriate payment for pediatric care. They measurably improve care and manage utilization and expense across the care continuum. Also, and this is an important thing, when independent pediatric practices can't bump into each other and say, well, so what are you charging for a 99213? That is an antitrust violation. It's illegal. You're not allowed to do it. On the other hand, independent practices can come together as a group in a clinically integrated network and develop models and strategies for care delivery, for care coordination, and for payment as a group. So it is a way for pediatricians, independent practices to legally negotiate as a group with payers. Most of these, to be clear, aren't funded independently. They're funded by local children's hospitals. And here they are. They're actually all over the country. So wherever there's a major children's hospital, these pediatric clinically integrated networks are now emerging. And it's not like they've been out there for a year or two. Many of these have been out there for more than a decade. So there's a body of work and experience that is now emerging. Is this you, Priya? Okay, good. And we've started a clinically integrated network for pediatricians in our market, the Pediatric Health Network. And Priya. Priya is our director of contracting, and she's going to walk you through some of the early work of our Pediatric Health Network.
Thank you.
Here's your mic.
Good morning. I'm Priya. I'm the Director of Contracting for PHN. PHN stands for the Pediatric Health Network, and as Dr. Weissman mentioned, it's the clinically integrated network funded by Children's National. This map shows the network, shows the practices that were in the network in December of 2018. So we were formed 6 years ago, and there were 39 practices that were part of PHN. Sorry, going backwards. Fast forward to current day, and this is a map of the DMV area and represents the practices that are in PHN today. So you can see the growth. Now we have almost 70 practices in PHN, close to 750 primary care providers. The blue dots on the map represent independent practices in the community, and the red dots are Children's National employed practices. So we definitely have more independent practices in the community. And with that, there are strength in numbers. What have been the key ingredients for success for PHN in the last few years? Of course, the first one is our primary care network. You saw the growth over the last 6 years. We have excellent leadership at the executive level, and we have great representation in our PHN committees. We also have a good staff at PHN on the leadership team, as well as in our contracting, quality, data, and IT teams. One of the things we're most proud of, Susan Metzler from our IT team has really focused on integrating data. And what that means is getting connections with the practices that are in PHN, integrating their EMR data, as well as we have payer contracts and we receive claims data, as well as enrollment data. And all of that data gets put into our data IT platform, Arcadia. And with that, we have the ability to create reporting and dashboards, not only at the network level, but at the practice level, as well as the individual provider level. And practices are trained on actually accessing Arcadia, and they can log in and pull up their own dashboards. And with having all the data for all the payers in one space, it makes it easier for the practice. They don't need to log into various different payer portals. One of the other priority focus areas for our quality team has been practice engagement with practices, as well as improving quality performance. And we have two quality consultants, Jessica and Erica, that meet with practices on an individual basis to go over the quality measures, what's required, They pass out coding tip sheets, and they also look at practice workflows to figure out how do we improve our performance in these measures. They also run the quarterly cohort meetings, which gives practices an overview of how we're performing as a network. Last year, we received formal legal recognition as a clinically integrated network. And this, as Dr. Weissman had mentioned, gives us the ability to negotiate with payers as a group. And finally, none of this could be possible without the support of Children's National. This is a snapshot of our board of directors, and you can see half of our board is made up of independent primary care physicians in the community. The other half are Children's National primary care providers, as well as specialists, as well as other administrative staff. And really, I just want to put this up there because these providers are true leaders in pediatric care, and they're also true leaders in their community. And a few of them I know are here today, so shout out to them. And so now moving into payer contracting, which is really what my focus is. PHN currently has 4 value-based contracts, 3 with commercial payers. Aetna, Care First, and United will start next year, as well as a Medicaid contract with the DC Medicaid plan. Some of these contracts are just focused on value-based components, so that would mean shared savings and focusing on quality improvement. But some of them, we've been actually able to negotiate improved fee schedules for our pediatricians. And of course, as Chip mentioned in the last presentation, there's always something to negotiate with the payer, so I'm always in constant discussions with different payers. Now moving into some of the challenges with value-based contracts in the pediatric space. So one of the things is most of the payers have a standard shared savings contract that is really focused on the adult population. Payers have limited data when it comes to pediatric focused models. Most of their spend is with the adult population. So when it comes to developing a specific contract for pediatric practices, they're really not interested. And so their standard off-the-shelf model doesn't make sense for pediatric practices. And that's because most of the work that all of you do is in preventive care, it's immunizations, it's those EPSDT services, it's health screenings. And those are all things that we would want to go up, right? And so that increases expense, but that's a good expense in my book. In addition, these programs require providers to hit certain quality targets. And for pediatricians, those quality targets revolve usually around well-child visits and immunizations. And so in order to meet or exceed those targets, you need to do more of those services. So again, costs are going up, but again, those are good costs. And finally, with the increase of behavioral health incidences in the community, a lot of that is being seen by pediatricians in primary care, again, generating, increased costs. And the way that the payers models evaluate your performance in these programs is they're looking at total cost. So they're looking at the total medical claims expense and the total pharmacy expense. And the bulk of the services that pediatricians are doing in their practice are increasing costs, but these are good costs. And so the models that are currently in place don't really make sense for pediatric practices. With that said, we were able to negotiate one novel contract with Care First, the largest commercial payer in our area. And that contract actually excludes, when reviewing total cost of care, it actually excludes the preventive codes, the immunization codes, most of those EPSDT services, as well as certain behavioral health psychotherapy codes that are being performed in a pediatric office. And by looking at that, it's actually then reviewing all the other expenses that are going up. And so pediatricians, thank you. So pediatricians then are not penalized for doing more of that the right care, providing the right care. In addition, PHN has rolled out behavioral health education, which some of you may have attended, and that comes in the form of monthly webinars on certain topics such as suicide prevention, autism, anxiety, as well as office hours with the Children's National Psychiatrist. So providers have the chance to bring their real world or real life cases to that specialist. And these are provided because, we know more and more of this care is coming to the pediatrician or is being seen in primary care. And so this helps to provide some additional coaching and tools that providers could use. There are still some challenges. Of course, payers still want to reduce costs. So they are still mostly focused on how do I reduce cost? And now if you are excluding the care that is provided in the primary care setting, really the remaining areas of how can we impact costs are really outside of the primary care setting. Whether it be ED, after hours care, pharmacy, specialist visits, et cetera. One of the things PHN is really now focused on in this next year is digging into that cost data and being able to give actionable items for practices to try and impact these costs. And I think I'll turn it over to Dr. Weissman for next steps.
Dr. Cressley, we appreciate the shout out, But actually, it's no small thing to get payers have their scripted cookbooks, and when you sit with them, they just sort of say, we don't have a model for that. Here's our adult contract, and it's just over and over and over. And I'd like to say it takes, 20 minutes of negotiation to make progress. It takes months and months and months to sort of move things. And credit to Priya and others for sort of their persistence and their sharp focus to sort of help deliver on this. So that said, we're here talking about how to make our practices more successful, and we want to improve our quality, get more kids in for well child visits, get the screening done, manage chronic illness, identify behavioral concerns early so that we can make a difference earlier as opposed to waiting for crises that invariably are stressful for the child and families and way more expensive with even more limited resources. So our next step value opportunities for pediatricians and pediatric CINs, we're going to continue to educate our practices and our pediatricians and our office managers about what the quality measures are and performance and how to improve those things. It's about improvement. We can't do this in isolation without giving thought about how to better connect, engage, and outreach to our families, because simply saying I'm going to do more of this is one thing, but actually getting our families on board is another, and we'll be talking a little about that later this afternoon with our conversations about social media. And beginning to look at where the lower hanging opportunities are for value in pediatric practice. And as Priya mentioned, even though it seems like we're costing more by doing all this screening and behavioral health work in our practices, identifying these things early and getting kids and families connected earlier in the long run is less expensive. So in the short term, it looks like you're spending more, but there's ROI downstream. We work a lot with our pediatric specialists. Kids are going back and forth all the time. I know it's shocking, but not necessarily every child referred to a specialist needs to go to a specialist right away. Some of that actually may be parental insistence. Some of that is we're busy. But that said, there are opportunities for us to work more collaboratively with our pediatric specialists around managing lower acuity concerns in your practice, getting the kids who need to get in earlier and getting them more appropriately managed, and returning some of these kids where appropriate back to you for follow-up, which creates more space for the other kids to get in. And we know there's an access problem with our specialists. And then lastly, there's after-hours utilization. There's all the care that we mobilize during our regular practice hours. But we know that families are seeking care sometimes when our practices are closed. Some of those are very appropriate visits to emergency departments for injuries or those sorts of things. We also know that in today's world, with our stressed out, overwhelmed families, some of our families are seeking care for convenience. And they sort of know the drill. Sore throat, needs a throat culture. Do I take off work? Do I, who's gonna cover the fort? Or I can just go to urgent care this evening. That's out there. We have to face up and address and recognize that that's how our families use care, and we have to sort of better understand and figure out ways to sort of deal with that. So this presentation is not going deep on that today, but we need to be looking, you as your practice need to be looking at your office hours, at your after hours access. Are there some things that can be done via telemedicine? And even counseling families that I do remember 15 plus years ago when Bob Graw came here and presented his idea about opening right time pediatrics for after hours care. The audience, this very audience, was not happy. And everyone was sitting there like this, like, what are you doing? You're cannibalizing our business. But he correctly assessed that this is what families wanted. And so I think we just need to recognize that and develop practice models that help guide families when they do seek care out of our regular office hours. What are cost-effective ways to do that manage cost and get them good care and appropriate care. So, am I doing the summary? I'm doing the summary. Okay. Current value-based care models are really designed for adult care systems and costs. Pediatric value-based care models should reflect a long-term investment in children and in equitable health resources and outcomes. The American Academy of Pediatrics, thank you, Sue, and the rest of the Academy, has developed a framework and recommendations for value-based care. It's also a framework for children and pediatricians, and actually maybe politicians. Pediatric clinically integrated networks have now formed around the country. Pediatric networks have formed around the country to better address the care, costs, and outcomes for children and better support pediatricians. And right here locally, our own pediatric health network has demonstrated some early success for our pediatrician partners in measurably improving quality and in developing some more pediatrician-friendly payer contracts. And we brought it in on time. Any quick questions? Oh. Oh, you want to repeat the question?
Yeah, the question was, is there any effort to negotiate with TRICARE for better rates? So right now, PHN is not negotiating with TRICARE. Really, our focus is the other big commercial payers.
But we can consider it. All right.